Yeah. Good morning, everybody. So we shall come to the first session of the second day in this hall, and that will be on refractive surgery. So how do you overcome roadblocks in refractive surgery by deciding on what patients to do and what kind of surgery to do, and more important than that, what kind of patients to avoid. So these are what we will be dealing with, along with what happens if you face an obstacle in the form of any intraoperative complication or post-operative phenomenon. So we'll start right away. I shall be, first of all, talking about how to customize the procedure according to what kind of patient you have. And I have no financial interest. So choice of refractive surgery in any patient depends on the age of that patient, on the lifestyle of that patient, type of refractive error the patient has, and the type of corneal topography that is reflected. So we know that these are the basic factors, and of course there's a range for each one of them. Now within that normal range, and with after excluding all other ocular morbidities and systemic morbidities, we have to choose the right patient, and that is what I'm going to talk about. So we're not talking about glaucomatous eyes or eyes with early cataract or anything of that sort, just normal eyes in normal patients. Now if you have a young patient who wants refractive surgery for an occupational purpose, like joining the forces, or maybe the requirement for some jobs that require extremely good vision or good binocular vision. So in such cases, when the refractive error is very low, it may be advisable to go for LASIK and sometimes trans-PRK rather than a more invasive procedure like SMILE or maybe phakic intraocular lenses. Now if it is low to moderate in the range, so now the first one was in the range of 0.25, 0.5 or a 0.5 cylinder, which does not give the patient a refractive a visual acuity of 6/6, but is somewhere in the range of 6/9. And this is a deterrent for a very critically selected occupation. Then such kind of a procedure may be optimal. But of course you will counsel the patient to the effect that there is always a chance of overcorrection, undercorrection, and so on. Now, if you're dealing with a low to moderate patient, so here we are talking about someone who has some myopia in the range of, let's say, -2 or some astigmatism, then laser vision correction as well as phakic IOL, depending on what the topography maps show, is the ideal procedure. If you're talking about a high myope or a very high hypermetrope that does not come within the purview of LASIK, or they have corneal indications which prevent you from doing any form of laser vision correction, then phakic IOLs and bioptics. So phakic IOLs or IOLs combined with top-up laser or maybe a refractive lens, something above 35 to the tune of anywhere around 50, 55, so long as there are no other comorbidities. First of all, if you're doing a pure distance vision correction, it's very important to counsel the patient that they are going to develop presbyopia, because most myopes in this age range, they don't like wearing bifocal glasses. They always keep their single vision glasses on, and they lift their glasses to see near. So these are patients who are going to be shocked the next day when they find out that they're not able to read near, not able to see the grains in their food, or put a bindi on their head and all that. So it's very important that you counsel them that presbyopia is going to have an onset the very next day after laser vision correction. Now, in case the candidate is suitable for a blended procedure like Presby Max or Pres Beyond, where you use aberrations, or where you use increase the depth of focus, so such corrections can also be applied. Again, that depends on the indication. And of course, in the offing is the presbyopic IOL, phakic IOL by EVO, called EVO Viva. So when that comes to India, we can, I hope it provides a lot of relief to us. Then of course refractive lens exchange is also a very good option in such patients, especially over the age of 40, even if there is no cataract. Again, you have to make sure that the posterior segment is pristine, there's no pathology that you have to deal with there, and that's very important in such patients. Now again, the lifestyle, depending on whether you are into combat, like one of the forces, or whether you're into contact sports, you might need to choose a flapless procedure like SMILE or trans-PRK, maybe ICL, though I may not be too much in favor of it because anyway you've created an incision. And if you have a chance of high UV exposure, like for example in surfers or in yachters, those that go out in the sea and might not be able to wear a UV protection all the time, it may be better to avoid a PRK, a surface procedure, because the chances of developing fibrosis and regression are much higher, and you can go for a flap-based procedure like LASIK, or a flapless one like SMILE, or even a phakic intraocular lenses. So this is how you customize it depending on what situation the patient is in. Then of course you have conventional choices for the type of refractive error, as we have been taught all along, that when you have a myopia that is anywhere higher than -6, you can choose a trans-PRK with MMC, but less than that you can avoid something with, you can avoid MMC, but right now I use MMC for all refractive errors with trans-PRK, because I've seen that even astigmatism as low as 2 or 2.5 can lead to subepithelial fibrosis. Now any high range refractive error to prevent an oblate cornea, it may be better to go in for a phakic intraocular lens. And in high hypermetropes, which don't come in the purview of laser vision correction by way of topography or by way of the magnitude of the power, can go in for refractive lens exchange or a phakic intraocular lens. Now the most important part is the wetting of the topography. So if you see something obvious like this, where you have a very steep anterior and posterior cornea with a low pachymetry, then it's a strict no. You have a skewing of the axis or a superior inferior asymmetry, you have an obvious cone, it's a strict no. But then you would have certain patients that are somewhere in the borderline, and you may need to decide whether to go in for laser vision correction or phakic IOL, or maybe sometimes neither. So here you can see that there is a patient who has high astigmatism. This is someone with 5.5 diopters at 180 degree. You can see that the cornea is relatively okay. So it is 469 over here. And now this patient, I have put a limit of 470 microns for all my laser vision correction patients. So in case I do an astigmatic treatment, maybe the cornea will bear it. I don't think there'll be much of a problem. But still, I would not do it, because there is a point where you have to say no, and if you keep either 460 or 470 or 500, whatever your correction, I'd suggest not to go below 470. Then you should say no, however small the correction is. So with a good AC depth of 3.65 and a large white to white, you can see the topmost number 12.9. So this patient is an ideal candidate for an ICL. Now coming here, you have a high hypermetrope plus 9 diopters, and you can see that the cornea is very steep. So there is no question of doing a laser vision correction here, because you're going to further steepen the cornea. Now coming to the AC depth, you can see that it is very shallow, 2.65, whereas you need at least a 2.77 or 2.8 to do an intraocular lens. So this may be a patient who is suitable for neither. And in such a circumstance, depending on the expectations of the patient, you may think about doing a refractive lens exchange, which may be a better option for this patient. Now, if you consider this patient, you can see that he has a moderate refractive error to the tune of -6 diopters, and a very good pachy of 591 microns, and a very shallow, anterior chamber depth of 2.31. So now if you look at the cornea, it has an average pachymetry of around 41 diopters, and such a patient, when you do a -6 correction, will go to somewhere like 34, 35. So anything beyond 36 or 35 makes the aberrations magnify, and so laser vision correction might not be an option in this patient with flat cornea, though he has a good pachymetry. On the other hand, if you want to go for a phakic IOL, the chamber is too shallow to take that IOL, so it may be a good idea not to go for a phakic IOL either. So these are the patients where you have to look into each and every aspect before you zero in on a particular treatment. You also may have, it's not compulsory, but you also may map the epithelium, and sometimes, there are some clues as to very, very early ectasias when you check the epithelium. And of course, I believe that endothelium, whether you're doing a laser vision correction or an ICL, is very, very important. So the dictum is that the refraction has to be stable. Whatever correction you're doing, whichever modality, and always try to, pick up small markers that may be present in the patient profile. So here you have a young patient with a relatively normal kind of refraction. He had an earlier history of unstable refraction. Now, he has been stable for the past 8 months, and you can see that there's something abnormal about the refraction there. The eye which has a higher error seems to have very good vision, whereas the eye with the lower error has, a corrected vision which is quite low compared to the other one. So that's a bit paradoxical. Now you come to the maps and you see that there are indicators everywhere, whether it be the pachymetry or the anterior and posterior elevations or the steepest K. So you can see that all these parameters have some or the other red markers, which may not be very gross, but are subtle. So you can see that both the 3 and 5 mm zones have high irregularity. The thinnest pachy is less than what is suggested. The mean CCT is less, the max K is borderline, and there is gross inferior and superior asymmetry with elevation of the posterior floats. So in all these cases, especially with skewing and such, obvious topographies, this may be avoided. And then if you look at the other eye, you can see that it looks pretty normal. Everything is within the normal range, and that's when you realize that keratoconus is an asymmetric disease. Even if you have a completely normal topo in one eye, you have to think of the presence of formae fructae keratoconus in the other eye, and that patient better be avoided. So the condition that needs to be treated here is keratoconus and not refractive error. So you go in for a format like C3R before you go in for a maybe another procedure like a phakic intraocular lens. Then of course patient counseling is very important, and you have to be very dot on, telling them beforehand what to expect, and afterwards how to continue with the medications, the precautions. So an ICL is a good option in a lot of patients that we have seen topographies of that cannot undergo laser vision correction, and that is basically because it is present very near the nodal point of the eye. It has a stable location far away from the endothelium. So here we are talking about a posterior phakic IOL, unlike the rigid anterior segment phakic IOLs that used to be there before. And the plate haptic design keeps it very stable. These are the optic parameters that we have. And of course, all the measurements need to be right. So the white to white, or whether you're going for the anterior chamber depth, it has to be very accurately measured. Then the lens is a pliable material. How you draw in, all that is very important to give good results. How you orient the lens, whether it's manually or using a Varion or any image guided system, is very important. Then once you insert the lens, the maneuvering should be minimal so as to prevent any form of pigment dispersion, especially while doing IA. And then these lenses can also be kept as piggyback lenses. Now this is a post-trauma eye with a high refractive error and a PCIOL in place. So the high refractive error can be corrected by keeping the ICL over the IOL. Just be sure that there's no residue in the interface. Then again, vaulting, I think, will be talked about during the complications. So these are how you divide between laser vision correction and phakic IOL. So I think we'll proceed with Dr. Rajesh Sinha. He also simultaneously needs to go to another session, and he'll be back after. So he'll be talking about how to manage complications of laser vision cataract surgery, laser vision correction.
Thank you. Thanks, Dr. Swapna. It was a wonderful talk. We just want to, for my knowledge as well as, many times we keep discussing what should be the cutoff, pachymetric cutoff, whether it should be different for LASIK, different for surface ablation. So any comment? We have some of the experienced refractive surgeons. Anand is here, Amrish is here, there are many other people. So any comment on any difference in pachymetry that you keep for PRK and for any flap-based procedure or a smile?
I think the minimum pachy we look for is 490 microns. Anything less than that?
For LASIK, for flap-based? For
flap-based.
Okay. And for PRK?
For PRK, we do it around 470 also.
470. So, I mean, that is the minimum that below which we should not do any laser vision correction. Procedure. Okay.
Your parameters, Anand, do you have any specs? Same as Dr. Amrish was saying.
Yeah. So thank you very much. It was a very nice introduction first regarding decision making in refractive procedure. And refractive procedure is safe. All these refractive procedures are very safe, but any and every procedure has some risk of complications. And I'll just be dealing with the complications of laser corneal refractive surgery, like smile, LASIK, surface ablation. So this was the whole classification that was given. So first, coming to the complications related to flap when we create in LASIK, there can be flap buttonhole. Now flap buttonhole is, as you can see here, this uncut part is there, and that is called flap buttonhole because there's a buttonhole in the flap. So if there is a buttonhole, you have to reposit the flap and do the procedure a little later, maybe after 3 months, when you can again cut it, either with a microkeratome, you can use femtosecond laser, you can also do surface ablation in these cases. It was just a thought that femto LASIK does not cause any buttonhole, but yes, it's extremely rare in comparison to microkeratome. Even in microkeratome, if the keratometry, etc. is fine, then the risk of buttonhole is very less. But if it's a steep keratometry, then there is chance of buttonhole, and that's why any keratometry more than 46, I don't advocate using microkeratome, would prefer doing a femtosecond laser. But even in femtosecond laser, you can have vertical gas breakthrough, and if that is the case, then that area remains uncut, and then we should avoid the surgery and do it at a later time. And if you have a bubble in the anterior chamber, then in that case, people do, put off the tracker and do it. That is one way of doing, but that may not be the most ideal way of doing it. The best thing is that you can wait for a few hours, and once the bubble becomes a little smaller when your tracker starts working, then you can do with a better result. And sometimes you can have incomplete flap. Now, because of motor jamming, suction loss, drapes, etc. So if you have a flap which is incomplete, maybe somewhere here, you can do a dissection and go ahead. But if it's, bisecting the pupil or lesser than that, then it's better to avoid and deposit the flap and do surface ablation at a later date, or maybe you can recut at a later date. Free caps are mostly seen with flat corneas, and if there's a free cap, if the size of the cap is adequate, like you have intended to make a, say, 8mm flap, and if it's a free cap of 8mm, you can go ahead and do a laser, put the free cap back onto the surface and dry it. And these days we have even fibrin glue available. You can put a little bit of fibrin glue at the edge, put a bandage contact lens, and that works well. Incomplete femtoflap can also be seen due to suction loss, and it depends at what stage it has happened. If it's less than 10% of laser that has gone and then there's a suction loss, you can just repeat the procedure. But if it has gone beyond that, somewhere between 10% to 100%, somewhere around 80% of laser has gone, then if you repeat it, then you can have irregular planes. So it's better to reposit the flap and do it at a later date. Sometimes your side cut, the pocket cut, that is only, that does not happen. At that time there is suction loss. In that case, you can reduce the size of the cap and do just a side cut so that you can remove the lenticule. But that should be done only just 0.2 millimeters smaller. You can't go much inside, otherwise you will not be able to dissect the lenticule. If there is a torn hinge, then in that case, you can once again lift the flap and complete the procedure and reposit the flap and just see to it that the edges are well opposed, because there is risk of epithelial ingrowth in such cases. So the edges should be well opposed, and put a bandage contact lens in this case. Sometimes you can have a torn cap with the femtosecond laser as well, and as in this case, as it is being tried to lift, you can see there's a torn cap here. So that can happen sometimes because of too many patients you have in your OR when you are in a hurry to do all that. So it can happen. If it happens, then you can lift the flap, do the ablation, reposit it, and once again see to it that the edge apposition is appropriate so that the epithelial ingrowth risk is less. There can be torn cap in SMILE as well, and this happens mostly when you are removing the lenticule, and that is why it is better, and what I prefer, I bend the forceps so that when the forceps is bent, then in that case it will not push the edge of the cap too much. As you can see here, it is just pushing it and causing tearing of the cap. Again, torn cap in SMILE. Once again, because of the manipulation while removing the, either while doing your dissection of the lenticule from top or from behind, or when you're removing it. So you have to be a little careful in these, and during initial learning curve, it's better to make a slightly larger incision in the cap, nearly 4 millimeter. So we used to do it with 4 millimeter earlier, now we do it with 2 millimeters. So with experience, you can do that. There can be incomplete lenticule removal in SMILE, and that can happen because of incomplete dissection. So in such cases, what you can do is you can either stain. If it's it is not advisable to pull the lenticule, because these are thin lenticules. If you pull it too much, if it adhered and you pull it too much, then there is a chance of it tearing up, and then you will have a risk of some part of lenticule left. As you can see here, I'll just improve the light. So some part of, when you spread it on the cornea, you will see that some part is left. In such cases, either you can use steroid, triamcinolone, to stain that, or you can use microscope integrated OCT to look for this thing. So as you can see here, incomplete lenticule removal, which can be removed by microscope integrated OCT guided lenticule removal. So as you can see here, this is the case wherein there was some lenticule left. So when you go in, then you will see that there is some intraoperative OCT will show to you the lenticule which is left there, the exact position of that, and then you can remove that. So that is very much doable. And after that you can check and remove it. As far as flap stria is concerned, it can be seen if you have excessive ablation and a thin flap, and that is a combination that can happen if there is a high refractive error. And sometimes also because of some trauma. It depends on the duration of flap stria. If the flap stria has happened early, you see the patient on day one and see that there's a flap stria, then you can just relift the flap, refloat it and reposit it back. But if the flap stria has happened a little later, or the patient has reported to you a little later, in such a case it is advisable to debride the surface epithelium and swell the stroma of the flap, because that will stretch the collagen lamellae and that will get rid of the stria. So it's very important to do that, then refloat and reposit it back, and you will get a nice post-op picture. This is a case wherein there was a flap dislocation with flap stria and because of trauma. So again, with epithelial ingrowth, so in such a case, once again you lift the flap, you debride the epithelial ingrowth, and then once you have debrided it, you do stretching of the flap. But I'm telling you from practical experience, all these ironing and stretching, it doesn't help too much. Once again the flap stria comes back. So the best thing is to debride the epithelium and hydrate the stroma of the flap. That is the most important thing in order to get rid of the flap. This is how it looks like. This patient came to us 2 weeks after the trauma, but the flap stria disappeared completely. Epithelial ingrowth normally happens from the periphery, as you can see here. This is the area from where it has gone, and when you put a fluorescein, it will stain that area. But sometimes if there's a flap buttonhole, then you can see the epithelial ingrowth from around this area as well. And you can see the epithelial ingrowth only in the paracentral area, not coming from the periphery, and that is coming from a flap buttonhole. It is not very common, more often seen with hyperopic LASIK because the peripheral adhesion is not that great. And as I said, if there is epithelial ingrowth, you lift it up and then you can wash it off. But sometimes what happens is that epithelial ingrowth is so dense that you have to do flap amputation. As in this case, you see the OCT, the epithelium is actually entering into the flap and you just cannot manage it. So in such a case, it's better to do flap amputation. Flap amputation is very simple. You just lift the flap and you can amputate it. You remove the epithelium and then amputate the flap. The biggest worry is that if you amputate the flap, how much will be the refractive change? It is not equivalent to the thickness of the flap. Most of the cases, you do have a flap thickness of, say, about 100 microns, 90 microns, 110 microns, and the residual refractive error after flap amputation is mostly about +1 diopter. Some degree of astigmatism can be seen. This is how it looks like in the post-op period. Maybe you can have 0.75 of astigmatism and plus 0.75 of sphere. This is the flap buttonhole that caused the epithelial ingrowth, and is it 1 minute or? Okay, I'll just. So this is the flap buttonhole through which the epithelial ingrowth has happened. So in such a case, you should not reposit the flap. Remove the epithelium completely. I'm using alcohol to soften the adhesion of epithelium, and then with the help of lamellar dissector, removing this part of the stroma that is there, the island, and then mitomycin C has been used, and you put a bandage contact lens. The epithelial ingrowth can be seen even after a smile, but very less frequently. Under a overcorrection, you do re-LASIK. If there is a post-LASIK ectasia, then RGP contact lens is the mainstay. You can also do intracorneal ring segment. I'll just skip the video because of paucity of time. DLK is something that can be seen in various stages, and if in the initial stage you can just manage with steroid, but in later stage you have to relift the flap and wash it completely. And if you have a post-LASIK infectious keratitis, one thing that I would like to tell you, we treat keratitis just like any other keratitis, but flap amputation is a must. That is most important thing in post-LASIK infectious keratitis. This is a post-LASIK infectious keratitis wherein flap amputation has been done, and it worked very well. This patient is now having a visual acuity of 6/9 partial. So the response to antimicrobials only happen or usually happens when you do a flap amputation. You can get material for microorganism identification as well. I just skip this. Surface ablation can cause corneal haze if it is too much. So that's why, as Dr. Swapna was telling, we should use mitomycin C in almost all the cases. And I'll just move on. And so the last point is that how much mitomycin C we should use, 0.02% for 45 seconds, 1 minute. It is variable with different people. I use it for 45 seconds if there is a haze, if I'm doing a PRK, and if there is a haze, in order to treat that, I use it for 1 minute. That is what I do. So thank you very much. Any comment on that? I'm sorry I had to rush because it is a bit extensive topic to cover.
I know it's a whole chapter. So have you had experience with subepithelial fibrosis and treatment of that following high myopic corrections or PRK?
Yes. It has happened with PRK, it has happened with LASIK, that we thought earlier that if we replace the epithelium there won't be any haze. Yes, we have seen that, and in order to treat that, that's what I said, that if we are treating that, we will do PTK if the haze is significant. Then in that case, we will use mitomycin C for a little longer, maybe 1 minute. Some people have used it even for up to 2 minutes, but I prefer it using for 1 minute.
And for trans-PRK, have you had corneal melts following the use of mitomycin C?
Till date, fortunately, no.
Yeah. So I just wanted to, send the message that it is a safe procedure if used in the right concentration and for the right duration of time.
Sorry, the smile lenticule got left, the residual one.
Yeah.
Is it because the dissection wasn't complete?
Yes. Yes, it is. It's because if you don't dissect completely and try to remove it, and then you think that maybe I will pull it and take it out, that doesn't happen, because the peripheral part, these lenticules are thin, and if you put too much of pressure in pulling it, sometimes what happens that it gets torn and little bit of it is left behind.
Yeah, our learning in the initial cases of smile has been, Rajesh, one, make sure that the dissection goes above and below the lenticule 360 degrees.
Yeah.
Even if there's a bit near the incision, sometimes for small incisions, because of the overlocking, slightly difficult. But the peripheral up to maybe 1 clocker on each side will come off. Usually what we tell most people who are learning it is to push it away and then bring it out, so that the edges near the incision also get cut.
Absolutely.
The second was the type of instrument. The femtosecond flap intraoperative, where you had this thing, it very common if you're not careful with the tip.
Yeah.
And so what we tell them is, don't lift the flap but press down the stroma. So mentally we say we have to lift the flap, so we put pressure on the flap, but actually you should press down on the stroma, then the flap comes off easily.
And in smile, when it is left, what we do is that mostly it happens when you dissect it completely, one side you have dissected below or above, whatever you prefer, and on the other side when you are dissecting, if you dissect on one side completely and then go to the other side, then there is chance of that lenticule getting folded. So then the dissection remains incomplete. So the best thing is that you dissect on one side, leave the central part, then you dissect here, and then just leave the, just at the pocket you leave that, because then, as you said, that you can just push it and then take it out like a rhexis. And then dissect the distal part and then dissect here. So this is what, if we practice that, then it will not happen.
I think these are important learnings for somebody who's learning the smile, rather than them making the same mistakes.
Absolutely.
And the patient paying for it.
Yeah.
I think these points need to be put together in like 10 major points by AIOS for smile users, because the number of people who are going to shift is going to be more.
Yeah, true. That's true. Thank you.
Thank you, Dr. Rajesh. So we'll just briefly go through how to manage phakic intraocular lens complications after the laser vision correction complications. So now, as I had mentioned earlier, counseling, measurement, and ruling out unstable refraction are very important. Now, if you, when you're doing the procedure, it's important that the intraocular lens be injected very slowly, because even after injecting a majority of the lens, in case you find that the lens is flipped, there is always a possibility that you can slowly twist the cartridge and make sure that the lens comes out the right side out. So it's very important that you inject the lens slowly. You shoot the lens in, that's not possible. But even when 5/6 of the lens is out of the cartridge, there is still a possibility that you can turn in case of a flipped intraocular, phakic intraocular lens. Now, sometimes a pupil distortion might indicate that the lens you have placed has one of the haptics lying outside, and you just need to go back in and, you know, tuck it in before you complete the surgery, and then wash the viscoelastics out. But in case you have a very well dilated pupil, sometimes you may not be able to realize that the haptics are out, because the pupil looks pretty regular over here. And that's when you need a very careful eye. You need to tuck the haptics back inside before you exit. So in a large undilated pupil, you have to make sure that the transparent haptics are in the right position. Now, iris disturbances, especially when irrigation is done either by manual or by an automated IA, it has to be made sure that there is always a good flow from both above and below the ICL out through the side port. So for this, if you have an undilated pupil, it's very important that you dilate the pupil once more. So it's not only pre-operatively, but after placing the ICL also, you may need to dilate the pupil once more to make sure that the flow of fluid from beneath the ICL is very smooth and a channel is created, so that there is no disturbance of the iris at that point. So you can see that kind of a flow from beneath the ICL through the port should exist, and pupil dilatation is important for that. Now, this is another patient that is a very rare phenomenon, but I learnt about it after I went through such a complication. So this is Uret-Zavalia syndrome. Patient was normal on the first post-operative day. Regular patient, nothing abnormal in the procedure or in his refraction or in his eye. And then he comes back on the third day with severe pain and slight blurring of vision. And on looking, you can see that the IOP is raised, the cornea is hazy, and the pupil is atonic and looking like that. So now this I thought was a routine post-operative elevation of IOP, which is very, very rare, but I thought some visco might have got trapped somewhere. But this, even after the intraocular pressure was relieved, it took a very, very long time for the pupil to come back to normal. Even at 2 months, this is how his eye looked. And so this appears to be what we describe as Uret-Zavalia, usually following a keratoplasty, especially lamellar, after, you know, inflating the chamber, after overinflation of the chamber in lamellar keratoplasty. So I suspect that was the reason why this patient presented in this manner. Now, the treatment is, of course, reduction of the intraocular pressure. I've used pilocarpine also to try to reduce the pupil, but there is some amount of ischemia that is always left behind. Now, Now coming to this patient, now this was a patient post-trauma whose ICL had rotated. You can see that the markings where the re-rotation is attempted is very different from the way the ICL is oriented, approximately 30 diopters away. So that's very important. For each dioptric turn, for each degree of rotation, there is a 3.3% loss of dioptric power, especially in a high astigmatic ICL, and that's very important. So if the lens is rotated by more than 10 degrees, then that's 33% loss of power. So it's very important that the lens be rotated back, and that is done by gently lifting one haptic at a time and tucking it in, because the haptics are in close proximity to the zonules and we don't want to damage the zonules. So once the lens comes back to its position, then we can exit. So a high volt and a low volt are equally bad. Now high volt would lead to narrowing of the angle, pigment dispersion, and high chances of glaucoma. Some people have even considered endothelial cell loss or attrition to be higher in such high voltage patients, where the normal range is around 2 to 10%. That's usually just after surgery. So in such a patient, sometimes explantation of the ICL is what is important. So because the ICL is very pliable and it's made of a material that can be easily manipulated out of the anterior chamber without damage to adjuvant structures, that is the procedure. It can easily come out through a 3.2 incision, folded just like it was passed in. And sometimes if you find that's difficult, you can slightly increase the size of the incision, use the same instrument to hold the ICL. Now, cataract may happen in any patient either spontaneously or with a low volt. Now, this was a high myope who had cataract following trauma. And here the ICL implantation was done, the IOL implantation was done after keeping the ICL in the anterior chamber above the iris. So you can see that Rexis is being done under the ICL. Now the need for this was that he wanted a multifocal intraocular lens, a 35-year-old patient, and he was very used to good near vision, and he wanted to retain that. And I could not find a multifocal lens in that dioptric power had I removed the ICL, so I needed to keep the ICL in. And you can see the cataract is very soft, the patient being young. The most important thing is to protect the ICL with viscoelastic. High density viscoelastic is preferable, and the ICL, the IOL, once it's inserted inside and aligned well, the interface needs to be washed really well. Now this is also true when you're going to use an ICL as a piggyback lens in a patient with an intraocular lens and a high refractive residual error. So the interface needs to be washed so that there's no biofilm or bioresidue formed at the interface, and the patient does well with good vision. So I've done other cataracts also. Even after removing the ICL, femtosecond can also be done via the ICL. Now retinal detachment, this is another patient following trauma with ICL who developed a retinal detachment. So it was decided to retain the ICL, and you can see that the surgery is being done under the ICL. So visualization is very good, and you just need to be careful that you don't increase the intraocular pressure too much when you're doing scleral buckling to prevent signs of anterior segment ischemia. So these are some of the complications that you may need to deal with while handling phakic intraocular lenses. Thank you very much.
The very nice videos. I just had a couple of queries. One was regarding the vertical vault, Swapna. So if in spherical ICLs, it may be a good idea to try and see if you can put it oblique or vertical before exchanging it.
Yeah, because we know that, unlike the horizontal and vertical obvious diameters of the cornea that we see, sometimes the diameter along which you have placed the ICL may not be the maximum. And if you reorient it in any particular manner, then it may, get very smoothly tucked in. But that may not be a possibility with a toric ICL, as in
spherical. That's why I said spherical. Second was, I think, explantation of some of these phakic lenses is a challenge, especially the ones that are made of acrylic. So if you're looking at IOCare and the biotech, the Appaswamy ones, I think trying to take it out through the same incision that you put it in would be a challenge. I think most times you would need to increase it to 4.5.
Yes,
compared to the star ICL, which is a lot
very true, because the ICLs are much more thicker with, the phakic IOLs with the Indian manufacturers I've found to be much more thicker and slightly less pliable than the colamer lenses.
And last was, I think we had this discussion because I also have a patient post ICL cataract, which we did. One was that was a lovely video, but how did you do the calculation for the multifocal?
Yeah, I think that's a very relevant question, and the question that should be asked here. It's because I was the primary surgeon, so I knew what his refractive error was, and that is the target I put for calculation of the IOL. So normally when we calculate an IOL, we put the target as plano or 0. And then we take the IOL in a patient that we do cataract in. But in this patient, because I was retaining the ICL, I put the target as minus 12 diopters, which was the original refractive error of this patient, and then calculated the IOL, and that is how the lens power was determined.
So you basically, on the IOL printout, you go higher and higher on the expected residual refractive error.
Yeah, but you know IOL printout will give you minus 12, so you need to factor in the target as minus 12. So that your mean IOL power, the thing that is highlighted in your IOL box, that will give you a residual of minus 12. Yes.
For such cases, the ray tracing technology helps you in IOL power calculation. So you should use all the ray tracing technologies. So that will nullify that part.
Mm-hmm.
So use the oculics or phaco-optics will be useful for that kind of cases, particularly for IOL power calculation. Very nice presentation, ma'am. I would like to ask, which are the criteria for the explantation in high volt? All the high volt you will try to expand, or the IOP rise or any other?
Yeah. Very relevant question, because IOL walls as high as 1.5 times the corneal thickness may need not be explanted, provided the anterior chamber depth is very good. Now when you start seeing that the angle is very shallow, there is a lot of pigment dispersion, the chances of peripheral anterior synecdoche formation are high, are when you would require to explant the IOL. And if the AC depth is borderline, and you have put in an IOL according to calculations, but still you find that the angle is very shallow and you need to go one step lower. Such are the situations when you need to explant the IOL. Now before you actually go into a full-fledged glaucoma, these would be the preliminary times when you need an explantation. Any other suggestions?
No. Ambarish, anything you'd like to add? Okay. In the meantime, Dr. Pratmesh or Sri Lakshmi?
No, Sri Lakshmi.
Madam, my question is just on the ICL rotation. I have a patient after the ICL, who has a astigmatism of minus 1.5, and still there is a residual. On checking on the rotation, I find it is just about 5 to 7 degrees of rotation. So what should be the plan? Like, should we go back to the original axis which was calculated that the ICL axis should be at this level, or is there any formula to neutralize that astigmatism?
Yeah, so my question here is, was that patient a purely astigmatic patient?
Yeah, he had astigmatism.
Yeah. So I have also burnt my fingers that way, because there it is very important that you don't even have 1 to 2 degree of rotation. It's especially because it's pure astigmatic, so it's very important. So in such a patient where that rotation is happened, the best and the longest term treatment will be to just go in and flip it back to the original position.
Original only?
Yeah.
There is
that would be fine.
Calculation.com or anything that you can go to some...
Yeah, I know. That can be done for IOLs basically, where you can, do, that tells you how much to rotate, whether you need rotation or, But another option is if you had actually done the patient, but for 1.5, I don't think this would hold. You had not done a laser vision correction because of some, topographic indications, I assume. So top-up laser is also not an option. So I recommend that you go in and put the ICL back in the correct position.
But this patient I am facing a problem. I did one time that I put the ICL in the axis which was required there. But again, patient has a rotation. So why it is occurring and why the rotation
the
has
vault,
reoccurred?
or the vault, what would be the vault of the patient?
Vault is normal vault in this patient.
Because, yeah.
No,
Low
I think what,
vaulting.
what your question is that why is it going out of the astigmatic?
Because he's asking again, doctor, if you put it again on the axis, can it rotate again?
Yes, because the one reason for rotation is one is eye rubbing, which would probably a more common, right? The other is the undersizing. So if you go to the higher, if you want to go in again, I would prefer you increase the size by maybe 0.5, 0.25 if you have that depth available, and then put the same power on the axis and then see the chance of rotation are going to be less. A simple option maybe is to just try and do a laser vision correction just for that one. That would be the simplest.
No, but I am sure that the laser vision correction was not done in the first place for 1.5 because
But now we have to do only for 1.75 cylindrical power.
5, 6 maybe. The residual
for
power.
5, 6
It's just a residual power now.
Okay,
So maybe that option one can think of.
That'll be a simpler one. I think the more long-term fix would be to take that, increase the vault size and put it back.
Oh, thank you.
So now, yeah, Dr. Sri Lakshmi.
So good morning everyone. Today I will be dealing with the topic of presbyopia correction. So first when we are hearing about presbyopia, we will be thinking like, okay, it's after an age of 40 years, there will be loss of accommodation. It's not like that. Even after like a routine cataract surgery or a presenile complicated cataracts or a pediatric cataract surgery, like in every cases there is a concept of loss of accommodation. So what are the options for correcting this? These are trifocals or continuous range of vision, extended depth of focus lenses, enhanced monofocals, and like laser vision correction options like presbyopia or presbyon, then presbyopic ICL. This is an advanced concept. And the some corneal based procedures like corneal inlays like cameras, raindrops, presbyopia, presbyalens, and a scleral expansion based like scleral based procedure. So if you're considering the concept of a routine IOL procedure, the two most important things are like proper centration and astigmatism correction. So like the most important thing is like a proper centration of the IOL should be there, for that a proper capsulorhexis should be there. And you can see that the center of the lens and the center of the cornea is coinciding with the virion. In the center of the cross only, that center of the corneal reflex and the two Purkinje images, that is from the corneal center and from the IOL center is at the center. Now coming to the option of refractive lens exchange. So like wherever it's not feasible, usually in an older myope, like if you're considering the older myope, take an example of a -4 diopter correction. From -4 diopter correction to a +3 diopter correction, there is a huge way to go. And there is a lot of aberrations induced. So it's better to go for a refractive lens exchange in those patients. And next option is like where laser vision correction is not possible cases, and like ICL is not an option cases. Like a small wide to wide diameter, a small anterior chamber depth, and especially in ICL patients, we will go for a high myope, and there is more chances of retinal detachment after that. So like in all these cases, a refractive lens exchange procedure is better to do. And when we are considering the concept of pediatric cataract, like first of all, a proper anterior capsulotomy, capsulorhexis we have to do. Then a primary posterior capsulorhexis. Is everything is fine, then we can go for an option of putting an IOL. Previously we used to go for a monofocal IOL, but the present concept is like from studies like I have cited the studies there, like we can go for a multifocal IOL. If you're considering a child, through multifocality, there will be increased chance of better stereopsis power, and binocularity can be achieved earlier, and the amblyopia we can reduce to a much extent. The second concept of using a multifocal IOL is like there is increased chance of glares and halos, but the children's retina, like they have that capability of accepting that sort of glares and optics. So like they can go for multifocal if they are affordable. Then coming with the concept of enhanced monofocal, like there is an extended range of vision. When compared to a normal monofocal, there is an extended range of vision. But we can't confirm and tell the patient like you will be getting a good near or near vision. Intermediate vision will be better with them. Then coming to the laser vision correction options of Presby Max. This is just a standard procedure of laser correction. We are creating a flap, we are giving the laser correction, and they can go on. Next option is like Presby On, is a laser blended zone where like we are using the concept of micro monovision. Like one eye, like mainly the dominant eye, we are giving it for distance correction, and the non-dominant eye, we are going for the near vision correction. Now this is a scleral based procedure for presbyopia correction, like scleral expansion bands. These are basically PMMA bands that we are putting under the sclera near the ciliary vessels, ciliary muscle, under the ciliary muscles, and equatorial sonules are pushed, so thereby increasing the effectiveness and like presbyopia correction. But these are their own limitations, are not practiced as routine. Another option is like corneal inlay. So there are so many inlays like raindrop, camera, like everything. But the thing is like, with the help of femtosecond laser, we are creating a flap, and that flap is enough to insert that ring. An upcoming option is like presbyopic ICL. This like a wide range of population is waiting for an ideal method of correction for presbyopia. So this will be a promising one. In Europe, they are practicing it. Like this presbyopic ICL, like mainly for the myopic individuals or like those who have not started with that cataractous lens, like this is an ideal option. In all the concepts that multifocal IOLs and unifocal IOLs, why that great difference is there? Like because main thing is like glare and halos by the multifocal IOL. This is a comparison study. Thank you.
Thank you, Dr. Sri Lakshmi.
I would, Ambarish, any of the surgeons here?
I have two questions actually. One is, what is the ideal age you consider for refractive lens exchange? And typically, with the myopia of -4 diopter, just considering just to have a presbyopic correction, would you go for refractive lens exchange in those procedures?
Yeah, that is a very dicey question.
Because if you do LASIK in those cases also, that will increase the depth of focus anyway. So patient can have good post-op presbyopic vision also in that case.
Yeah, so again, I think the LASIK should be customized to the patient.
Exactly.
I mean, maybe you cannot do what you do for a 20-year-old. And if you're going for a refractive lens exchange, that there has to be high motivation for a power like -4 diopters. Because a very high motivation of not wearing glasses anytime and, any contraindication for laser. Otherwise, for -4 diopters, even for a patient under 45, I may not recommend refractive.
What is the age you consider for refractive lens exchange typically if a patient comes?
My cutoff is 45 actually.
45, yeah.
But my oldest patient is 56. Just for the clarification, my oldest patient is 56 for LASIK. Very clear lens, absolutely clear lens. -4 or 5 I think he had. So I discussed this. I said in 10, maybe 15 years you would require it. Now the only question is, what are they looking for? If they already worn glasses for 35 years, what is the intent of, is it to get I've become rich enough, now I can afford my LASIK, or I am getting middle-age crisis, so I don't want to wear my glasses. So these are probably the two, which you can make out during a conversation. And if you can do that, if they are okay with wearing presbyopic glasses at 60, I would still offer them LASIK. Because for me, even that 0.5% chance of an RD is something that I would really be discussing with them, because we did one maybe last week of -10, because she was very clear. Her daughter I had done SMILE for her daughter. She's 6'6". The lady was now 45. She wanted to say, no, I've been wearing glasses for 30 plus years. I want to get rid. I want to be young like my daughter. So ICL was not an option. So we went ahead with clear lens extraction with the understanding that you'll need a retina checkup for the rest of the life. But for hyperopic, the story is different. I will even offer it at 30.
Then presbyopic, even laser vision correction is quite better actually.
Any experience
Because I'm doing a lot of presbyopic treatment actually.
So presbyopic lasers, my experience has been equivocal. It would not be my primary choice, but
hyperope presbyope, the results are quite good, very good.
Very good.
The only mistake we commit when we do presbyopic laser in myope is we don't do the wavefront of the turn. So if you do the wavefront and if you can make out the depth of focus,
okay.
so probably then you can actually customize the treatment. And most of these platforms, whichever are available, are dependent on pupil size.
Okay.
So provided if you have a pupil size less than 3 mm,
okay.
then this hyperopic, because all these treatment, whether the blended vision or Presby Max or Presbeyond or Supracore for that matter, so what you are creating is you are creating a central bump. That's it. And that bump is in 3 mm zone. So if your pupil is less than that, you will get excellent result post-operatively. If that is not the case, then the results are quite dicey in those cases.
Okay. I think we'll move on to your talk, Dr. Anand. So Dr. Anand would be doing what Dr. Rajesh had not covered, post-refractive surgery, keratectasia, which is something that we all dread, and how to go about it.
Thank you, Swapna, for inviting me to be a part of this. There's no financial interest, but it would be nice to have some. I'll start with one patient of mine, government employee, underwent surgery, cataract surgery in 2001, referred to the cornea clinic as the last resort because the vision was not good post-surgery. And when we did put the patient on the scan, and that was time we had the op scan, this is the right eye and this is the left eye. And when we actually delved into the history, we realized that the patient had undergone LASIK by one of the renowned surgeons about 15 years before the cataract surgery. And this was actually post-LASIK ectasia, which was undetected during a normal scans. Patient disappeared, then came back to us 5 years later, and you can make out that the ectasia has actually gone up. The cornea is a lot more irregular, and across the pupil you have almost about 13 diopters of irregularity. So the quality of the vision, even with an IOL inside, is actually very, very poor. So what we did for this patient was to basically do a topography guided treatment. Just for explanation, what we did was the area that was flat on the topography was steepened, and the area that was steep was flattened. So this area of the laser where is directly on the steeper part of the cornea, which is the ectatic part. And with this is the post-op scan. So if you do the planning right, the aberrations come down. We put this patient on a eye trace. This is pre-surgery and this is post-surgery. So the clarity also tends to get better. If you look at the pre-post scans, this is pre of the right eye, and you can make out it's now oblique astigmatism can be corrected with a pair of glasses. Same way in the left, slightly less irregular cornea than what we started with. So if you do the planning for the topography with a stepwise approach, these patients actually do well. So when you imagine keratectasia, the picture on the left and the right requires similar management. You got to stop the progression, you got to stabilize the bulge, you got to improve the contour through intervention, and you need to have measurable results. Just for the information, that is not me. So there are some points for discussion. One is what is the incidence? Second is there any way to predict it? Any etiology, prevention? What is the literature on that? And the broad three procedures which are most common, is there any difference? And if there a normogram for the management. I did check the basic sciences because I have an interest. There is a difference in the enzymes in the tear film. So in alpha, especially at the level of the epithelium, so in the alpha protease inhibitors, which are almost normal in keratoconus, the others tend to have lower levels. The second is, of course, matrix metalloproteinases. These actually melt the cornea. So in dry eye patients, they tend to be also higher, and similarly in keratoconus. So the pathology in keratectasia and healthy versus keratoconus is slightly different. So this is something you need to remember. So the principles of keratoconus management broadly apply, but not perfectly. Now, what is the incidence across to my understanding is about 0.03 to 0.6% based on my literature review. And remember that we have gone up from 250, then we evolved to 275 to about 300. Now, I think there was a survey of corneal surgeons who look at 350 as a baseline. But all the residual bed thickness was based on the concept that the cornea has uniform strength from anterior to posterior cornea, which we know with histology is not true. So this concept is also probably not the ideal one. I do stress on pre-op slit lamp examination because what I find the minor lid abnormalities, the dry eyes, the cornea can cause chronic long-term inflammation. I have one patient of dry eye alone who progressed to keratoconus, and later we found it was a combination of dry eye and a mother having borderline keratoconus. So inflammation needs to be really looked at quite deeply. The concept of RSB has been there since we started LASIK surgery. So PRK is a better option if you even have a doubt in terms of form fruste keratoconus. And the RSB concept works better, remember, for LASIK rather than for PRK. For post-SMILE, when they looked a review of literature, they found that across the three factors which we look at, residual bed thickness, the ectasia risk factor score, and the percentage of tissue ablated, there is actually nothing consistent. You can have a range in the safe to the unsafe zone. Now, there are some preoperative predictors which have been mentioned in literature, which I mentioned, the ERSS. The sensitivity is up to be around 92%. But what the understanding is that it tends to underestimate for keratoconus suspect and overestimates for younger patients. PTA is said to be a better concept which has come in the last maybe about 10 to 12 years, which is PTA stands for percentage of tissue altered, and the predictability is about 97%, better than an RSB, and varies as per the procedure. Just remember that for LASIK it is considered about 40% as the upper limit. Now, increasing the ablation depth increase the ectasia, and there are of course some mathematical models for it. In SMILE, the modified PTA is now about 20%. Now, I also looked at a review of how much of ectasia occurs after SMILE, and they looked at all the factors of the 7 eyes out of this almost 8,000 eyes who underwent SMILE, and as I said that the range of PTA varies in the safe to the excessive range, but I guess 40 is said to be the mean, and that's the reason. There is one large study from India from Sri Ganesh's group, and they also find that for the standard SMILE there is no predictive factor, but if you do SMILE extra for borderline topographies, none of the groups that had SMILE extra actually even in the borderline developed ectasia. So that's probably an important take-home point. So based on all the retrospective application of the criteria, it could be the ERSS, PTA or RSB, my understanding over now probably 20 years of refractive surgery is the very important point of BB. BB stands for Bhagwan Bharose. That means you really don't know when and how you're actually going to get it. Now, there are some, of course, additional risk factors, which is the pre-op topography, pre-op thinner corneas, flap thickness, gender, and biomechanical variable, which is a concept which has come in now in about 15 years. Of course, biomechanics of PRK, LASIK versus SMILE are different. The tensile strength of SMILE is better than PRK and is better than LASIK. So that is an accepted concept. And every micron you ablate in the cornea, the tensile strength drops by about 0.2%. And if you increase the cap thickness, especially in patients with SMILE, it increases by about 0.08% for each micron that you increase. Now, corneal biomechanics was said to be the end all, but our present understanding is it probably adds some information but not a lot. Now, this is my broad paradigm for management of keratoectasia in early and advanced. So if you have regular astigmatism, and this is a slightly busy slide, so I'll go over it slightly more slowly. So if you have early to moderate grade 1 keratoconus or keratoectasia, if it's progressive and has regular astigmatism, you do a collagen cross-linking, give them good vision with glasses or contact lenses. You can use CXL in combination, and if there is a significant residual error, you can still put a toric ICL. The present understanding of intracorneal ring segments and cares is that it can be used for high myopic. It can make an irregular cornea a lot more regular, and then giving contact lenses or glasses makes it a lot more easier. If you have irregular astigmatism, you would still need to do CARES or intracorneal ring segments, follow it up with the collagen cross-linking or in combination, usually about 3 to 6 weeks later, and that can give good results as well. In advanced ectasia, that is patients coming a lot more later, quite rare, more common in keratoconus, where you have poor best corrected vision, less than 612, you would need to definitely think about a DALC. And DALC results with the present approach with the IOCT are actually very, very good. 80% of them get best corrected more than 612. If there is no central scarring but a broad ectasia, you can do hypertonic associated collagen cross-link or HPMC, and you can do a toric ICL for the residual error. Intax SK, if it's can be used for steeper corneas or CARES where you have 360-degree coverage, that can reduce the steepness of the cornea, and you can combine it with collagen cross-linking. In summary, the post-operative ectasia, though rare, has potentially devastating complications of corneorefractive surgery. The prevention is the best management, though screening is imperative. Consider lens-based refractive surgeries for those risk factors associated with post-operative ectasia. Identify ectasia early, halt the progression with corneal collagen cross-linking. This probably would be the baseline before you attempt to do anything else. Visual rehabilitation could include glasses, contact lenses, RJPs. Scleral lenses, very, very good results even for early and advanced keratoconus. You can combine it with surgical corneal procedures, and cornea transplant, at least for post-LASIK ectasia, is presently a last resort. Thank you so much, Swapna.
Thank you very much, Dr. Anand. I think we have come to the conclusion of both our time and our session. And
I have a retina surgeon who wants to ask me. I'm very keen to know what.
Anand, I just wondered if you have a borderline case. So what are the options available, whether you will go for a smile or you will go for an PRK, or what are the options you will give to the patient?
I would, depends on the two things basically. One is the thickness, second is the topography, third is the refractive error. So if these three you let me know, I can probably help you better.
No, if you think by ablation it will come to a border, somewhere on 410 or...
Ablation kitna hoga?
Ablation करके borderline पे आ रहे हैं हम.
What is the refractive power? If you remember?
No, if I come to a borderline somewhere on 410 or 250 bed strength.
This is with epithelium, without epithelium?
After the...
After ablation with epithelium, 400 is good enough. Yeah. 350 is now for low refractive errors. PRK is my preferred. Trans PRK works beautifully. Pain management is very good. Even for about 460, 470, we've done about 3 to 4 diopters. So that works quite well. Our cutoff for residual bed is 350 now. So that is uniform. Smile, if the powers are beyond -6, I would still consider smile. Implantable contact lens. Smile I would not consider for borderline cases because my contraindication for smile and LASIK is the same.
No, you said smile with the smile extra.
Smile extra is an option, yes. Or even PRK extra. Some people even do PRK extra. Just kind of give you the 10%. See, the extra part is how much is extra. Though extra sounds like some kind of medicine for...
So what is the plus minus range to go in to decide whether you will do an extra or you will not do?
Anything borderline, if you want to mentally just be safe, just go ahead. Because I think now the studies do show that even if it acts about 10-20% of corneal strength, and you may need to undercorrect the refractive error though, because it will flatten it by about 10%. So you would need to undercorrect your refraction, but it will give you extra safety.
Thank you.
Actually, sir, this is covered in the initial part of this. We would have loved to have you here. Wow.